Good evening, everyone. Good evening. Thank you so much for joining. Welcome to the World Diabetes Day seminar planned here for you by the Association of General Practitioners Jamaica and the wonderful sponsor, Apotex. We thank you so much for joining. Please look in the chat for your pre-test link and complete your pre-test now. You have 10 minutes remaining to complete the pre-test, and then I'll hand over to the moderator who will take you through a wonderful evening that's planned for you. Again, thank you to our sponsor, Apotex, for joining us, and thank you for taking the time out to join us tonight. Please find the pre-test in the chat, and of course, the post-test will be shared later. Alrighty. Good evening again, everyone. Good evening. You have approximately 8 minutes left to do your pretest. Approximately 8 minutes left to do your pretest. Please look at the link in the chat for your pretest. Thank you very much. Evening again, everybody. Just about 5 minutes remaining on your pre-test allocation time. Please note you don't have to request CMEs. The fact that you're logged in means that you've registered properly. So please don't request for CMEs in the chat. Simply do the pre-test and post-test.
Hello, Sam. Hello,
Hi,
Sam.
Dr. Gordon. Hi, Dr. Gordon.
Me? Are you
Yes,
hearing
sir.
me?
Yes, sir.
Loud and clear?
Loud and clear, sir.
All right. Thank you, Sam. Okay.
Thank you, sir. All right, ladies and gentlemen, you have 3 minutes remaining. 3 minutes remaining on your pre-test. So please go ahead, look in the chat, select the link that's there, and have your pre-test done. 3 minutes remaining. Thank you guys so much. So we have 1 minute remaining for the pre-test, and then I'll hand you over to the capable hands of our moderator for this evening, Dr. Aldith Buckland. 1 minute remaining for the pre-test. Good evening again, everyone. Again, I hand you over to our moderator for this evening's session, Dr. Aldith Buckland. Dr. Buckland, thank you so much, and we look forward to a wonderful evening. Over to you.
Thank you very much, Sam. Good evening, everyone. It is a pleasure to be moderator of this very important webinar, World Diabetes webinar on World Diabetes Day, November 14, 2023. It is truly a privilege for the Association of General Practitioners of Jamaica and Apotex to partner in bringing this webinar. I know that diabetes is a condition that all of us see so regularly, and it is a, shall I put it like this, a weapon of mass destruction. However, if we approach it a certain way, it may not be like that. And so together we can make a difference. Together we can help people to access care. And that's what it's all about. We know that access is not a simple matter. However, we can facilitate the access to care. We have two wonderful speakers coming to us. We know them very well, Professor Marvin Reid and Dr. Jacqueline Campbell. Both persons are very special to us because they have worked hand in hand with us to bring many wonderful guidelines in the past. Professor Reid is going to bring a really holistic approach to wellness and diabetes, because he's going to show us how together we can. And he will have many stories and practical strategies to share with us, to show us how we can inspire our patients and ourselves so that our patients and ourselves can see that it's all possible. Dr. Jacqueline Campbell, too, will indicate and guide us on the crucial components of diabetes management access to care, the balanced diet, and medication adherence. She will stress the necessity of accessible healthcare services, regular monitoring, and maintaining a balanced diet to manage blood sugar levels effectively. She will emphasize the vital role of medication adherence, providing practical tips for patients to incorporate these practices into their daily lives. I really just can't wait to hear them speak. And before they come to us, I will invite our association's president, Dr. Donald Gordon, to bring the welcome. Dr. Gordon, over to you.
Thank you, my esteemed colleague, Dr. Buckland, for that wonderful introduction. Good evening, everyone. I'm Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to welcome you on behalf of the association as we collaborate with Apotex in hosting another webinar to highlight World Diabetes Day. Welcome to our esteemed presenters, Professor Marvin Reid and Dr. Jackie Campbell. Welcome to Ms. Judith McBean and Abigail A. from Apotex, the sponsors and the collaborators of this evening's webinar. Welcome to our good old friend Sam from Oldgate Solution, our IT technical support team, who does such a wonderful job in making things stream so smoothly. A special welcome to Lynn, who works tirelessly behind the scene as the administrator to make everything possible. And last but not least, to your audience whose support we value and crave so much. I hope you all will find this evening's webinar worthy of the time spent. World Diabetes Day is a very important and significant event on the WHO Health calendar. It highlights the seriousness and the dire implications of the emerging epidemic of the rising diabetes incidence and prevalence worldwide. To get a glimpse of what we face in the future, diabetes is presently number 7 on the list of the leading cause of death worldwide, and it's the leading cause of death in Jamaica. Diabetes prevalence in Jamaica is 12%, with 40% of persons unaware of their status, according to the 2016-2017 lifestyle survey. With these statistics, the emphasis on diabetes is urgent and it's not misplaced. The theme of World Diabetes Day is broadening of access to care and the increasing awareness of one's status. One of the most critical issues is the lack of awareness about the presence of diabetes in the population and individuals. So the focus is on to promote awareness of the presence of diabetes in the general population. Once the population is aware of their status, then presumably the next goal is to educate the population to employ measures to monitor their diabetic status and to employ measures to prevent the onset of diabetes and to delay and to prevent the complications related to diabetes. We are indeed grateful to Apotex for once again partnering with the association to spread the message on World Diabetes Day of the impending epidemic of diabetes, and also to spread the message of hope in taking concrete action on the diabetes awareness and treatment. We hope that by focusing on the subject of diabetes, its management, and highlighting the dangers ahead, we'll be able to alter the trajectory of the oncoming avalanche of diabetes and its tragic consequences. Once again, we welcome you all, and we hope that at the end of this evening's webinar, the message will be well received. And over to you, Dr. Buckland. Thank you very much.
Thank you very much, Dr. Gordon. At this time, I will invite Mrs. Judith McBean, the Sales Supervisor for Apotex, to bring greetings. Mrs. McBean, come please.
Hi, thank you, Ms. Butler. Good evening, ladies and gentlemen. My name is Judith McBean, and I'm the supervisor for the Apotex team for the island. I once again have the pleasure to bring you greetings on behalf of Apotex on this most important day, World Diabetes Day. I know that by now many of you are very familiar with Apotex Pharmaceuticals and our goal of providing affordable, innovative, and high-quality solutions to patients worldwide. And of course, Apotex remains pleased to continue this partnership with AGPJ to bring you informative and educational presentations to enhance your knowledge and procedures and practices in the care of diabetic patients. As always, please remember the importance of the Apo prefix on your written prescriptions is to ensure that your patients receive the efficacious and affordable pharmaceutical option that you and your colleagues have been writing with confidence for the last 37 years, right? And nothing has changed in all that time. And I know that you can continue to trust Apotex to care for those that you care for. So thank you and have yourself a great webinar.
Thank you very much. We will have the sponsors video presentation at this time. Thank you.
Since 1974, Apotex has been committed to helping enrich lives globally by providing affordable bioequivalent pharmaceutical products that meet the most rigorous quality standards worldwide. Since 2005, Apotex has dedicated billions of dollars towards the development of bioequivalent generics and more recently, biosimilars, over-the-counter products, and food supplements. Our manufacturing capabilities are recognized by regulatory agencies around the globe as meeting and surpassing the requirements of global healthcare agencies. Delivering quality products to our customers is at the heart of our business. Our commitment to excellence in quality, R&D, and customer service through an established network of international branch offices and distributors has enabled us to grow from our humble beginnings in Canada to a presence in more than 115 countries. With a manufacturing capacity of approximately 30 billion solid doses per year, we are able to reach new markets and grow in existing markets while sustaining our commitment to excellence. Through our strength in research and development and our sustained dynamic intellectual property initiatives, we challenge patents and strive to bring many key products to market sooner. The breadth of our product portfolio, together with our sales and marketing strength, make us #1 in Canada, as well as having a leading market presence in Australia and US markets. We are also vertically integrated into many raw materials, helping us to drive synergies across many key products. We are proud to say that we continually donate medicines to disaster zones around the globe. As leaders in our industry and as individuals, we make an impact. We learn and adapt every day. We will continue to be recognized as a global leader by continuing to build valuable long-term relationships where customers get the products they need when they need them. Apotex, helping enrich lives globally.
Thank you so much for that video presentation. All right, so the time of appearance is at hand. Professor Marvin Reid is the Deputy Dean and Graduate Studies and Research at the Faculty of Medical Sciences at UWI Mona. He's a past director of the Tropical Metabolism Research Unit, Caribbean Institute of Health Research, and associate lecturer in the Department of Community Medicine and Psychiatry at the University of the West Indies, Mona, the UWI. His research interest spans the gamut of community medicine, clinical trials, and human metabolism. He has co-authored over 140 peer-reviewed articles and has received the Monocampus Principals and the UWI Vice Chancellor's Award for Research Excellence, as well as other international awards for research publications. Professor Reid practices as a family physician in a group practice and is a member of the Family Medicine Specialty Board at the UWI, which advises on postgraduate family medicine training. He is a member of several national, regional, and international professional bodies, such as WONCA, the Medical Association of Jamaica, the American Physiological Society, as well as a member of the Research Advisory Committee of Caribbean Public Health Agency, CARPHA. He is a fellow of the World College of Family Physicians as well. So please help me to welcome Professor Marvin Reid, who is bringing the keynote presentation on Together We Can, a holistic approach to wellness with diabetes. Professor Reid, your time to fly the plane.
Thank you so much, Aldith. Good evening, colleagues. We're going to be moving right along. Dr. Gordon, thanks for, as I said, rolling the wicket for me so that we can get cracking. As was mentioned, today is the day designated to highlight diabetes as a health concern. And so the Association of General Practitioners have sought to embark upon this webinar as part of their celebratory activities around World Diabetes Day. So the title of my talk today is Together We Can, a holistic approach to wellness with diabetes. So what is it that we hope to achieve by the end of our lecture? Well, basically, I'm going to be focused on an approach which is called a chronic care model, which is an approach that has been put forward by the World Health Organization and PAHO as a mechanism to provide a more holistic care for individuals who have chronic diseases. When I understand and briefly describe the principles of screening and diagnosis of diabetes, describe the pillars of lifestyle management of persons with diabetes, and of course, describe the principles of the pharmacological approach to management of persons living with diabetes. So let's get cracking. So what is a chronic care model? The chronic care model essentially is a concept whereby we look at the outcome, which is informed, activated patient who is willing to participate, be an active participant in their care journey. So within that concept, we do not like the usage of the pejorative term, like a diabetic and so on. But what we're trying to emphasize is that before us is a unique individuals who happens to have a particular issue as part of their life journey. And in order for us to satisfy and care for the circumstances of that individuals, we really need to have a prepared and proactive team of individuals who is in a bilateral or interactive interface with this informed and activated patient. But to facilitate that interaction, there are certain environmental factors which have to be in tuned and facilitatory to accommodate the interactions. These environmental things include at the level of the family, whatever support groups or support individuals that might be available, the respective resource, which may be both human, financial, as well as physical. Then we look at the health system, which is going to be the guiding system through which some of these interactions will be allowed to flourish. So within the health system, mechanisms to support individuals managing their illness, the design and delivery of the health system, how care is delivered, and clearly the decision support system that exists within the health system is also important, and clinical information system, which amongst other things enhances portability by or activated patients. So this is basically the main components of the so-called chronic care model. And the PAHO recommends that this chronic care model should be the basis or center under which we provide care to the population of individuals who may suffer from chronic disease. So within that concept, all aspects of the chronic care model are important. So when we think about looking from top down at the health system and looking at the services that we provide for individuals with chronic disease, we have to ensure that we are practicing and implementing all the components. It focuses on a patient-centered approach. Clearly, policies both in agriculture, in legal, in health, in education, policies should be multi-sectoral, and these policies need to ensure that they touch across aspects that may be important for individuals who have chronic non-communicable disease. Currently, Jamaica enjoys or practices universal access to care, and PAHO is recommended that in countries that don't do that, that become an important issue, an important point that they pay attention to. We certainly need to move along to improving the clinical information system module to support healthcare. We need to introduce systematic self-managing support system, which includes having the appropriately trained individual to assist patients to manage their chronic diseases better. Structure and provide the appropriate guidelines and training for healthcare providers to ensure that they can assist and manage persons on a more consistent basis. And also to ensure that chronic care is embedded in a primary care-led health system, which is fueled or sustained by multidisciplinary teams of health workers. So within the Jamaican context, Jamaica recognizes that the non-communicable disease is an important issue that affects the health of many Jamaicans. And therefore, there's a non-communicable disease unit within the Ministry of Health. And Jamaica has identified, similar to many other countries, what are its priority non-communicable disease. Included in the list of priorities are diabetes, hypertension, and cardiovascular disease, chronic lung disease such as asthma, and specific for the Jamaican context, sickle cell disease, cancers, and depression. So how do we at the public health level address the epidemic that Dr. Gordon spoke about in his introductory remarks? Well, as scientists, physician scientists, we recognize that interventions that are not supported by evidence are really interventions that are based on hope. And that may not lead, usually does not lead to good outcomes. So where do we have some of the evidence rather for interventions that seems to work? PAHO has put out a set of recommendations which, if implemented at the public health level, will go a long way in reducing the burden of non-communicable diseases, including diabetes. So some of these best buys include the reduction of tobacco use, the reduction in the harmful use of alcohol, the promotion of a healthy diet, the promotion of physical activity, screening and diagnosis of diabetes, and cardiovascular health, and where cancers are concerned, especially for those for which we have health preventative activities like cervical cancer, the issues of vaccination, and certainly for breast cancer, the issues of breast cancer screening. The PAHO has provided these bits of evidence that at the public health level will help to address some of the burden of the non-communicable disease. The talk today really is focused on diabetes. And so the issue is, what is the definition of diabetes? So in association with clinical symptoms, which many of us will know, issues of weight loss, hyperphagia, polyuria, may have weight loss, recurrent infections, we recognize that we support those clinical features with laboratory diagnosis. And the laboratory diagnosis is focused on, despite the fact that we recognize that diabetes is a multifaceted metabolic disorder in which all aspects of human metabolism is affected, the primary manifestations are related to abnormalities in glucose metabolism. And within that context, most of the laboratory diagnosis is really focused on measures of glucose metabolism or this metabolism. So we look at hemoglobin A1C, and so individuals who have a hemoglobin A1C more than 5.7 but less than 6.4 is considered to be on the journey to becoming diabetic, so they're pre-diabetic. And individuals who have a hemoglobin A1C more than 6.5% are considered to be diabetic. Fasting blood sugar, the range here is over 7, you're diagnosed as diabetic. And if you're between 5.6 and 6.9, you're considered to be pre-diabetic. If you did a 75 grams or a glucose tolerance test, the threshold for the diagnosis is more than 11.1 at 2 hours for diabetes. And if you fall within the range of 7.8 to 11, you're considered to be pre-diabetic. And at any time, if we were to do a random plasma glucose and it's more than 11.1, you would be considered to be diabetic. The American Diabetic Association recommends that we really should have 2 abnormal results from the same samples or 2 separate samples to actually confirm the diagnosis of diabetes. So now that we have established the diagnosis of diabetes, what is the prevalence of diabetes? Well, Donald recommended or suggested that the prevalence is about 12%. And yes, that's the numbers that we have gotten from the Jamaica Health and Lifestyle Survey 3, which was conducted between 2016 and 2017. And we're due to do another round sometime next year. The diagnosis of diabetes in that study was actually based on a fasting blood sugar greater than or equal to 7, or those individuals who are on diabetic medication. And what this graph shows is that essentially 10 years ago, when we did the Jamaica Health and Lifestyle surveys before, we recognized that at that time, the prevalence of diabetes was just about 7.8%. And we have increased tremendously over the last 10 years by a factor of at least almost 3% to a prevalence of about 10%. And this is between individuals who are 15 to 74 years of old. And then when we look at individuals who are over 75, the prevalence of diabetes is almost a half. So we recognize that as we get older, clearly there is an impact of the cumulative impact of our lifestyle, along with perhaps some contribution from selective mortality that allows the prevalence to be relatively high. Based on the data, a lot of that prevalence apparently is being driven by an increase in obesity, which occurs as we get much older. So with that said, one of the strategies that we can employ is that of screening. So what is really screening? Essentially, what you're trying to do is to identify diabetes at a very early age, even before there's overt symptoms, all right? So essentially, screening is defined by the World Health Organization as a presumptive identification of unrecognized disease in apparently healthy asymptomatic individuals by means of test or examination or other procedures that can be readily applied. And then once it is that you've identified individuals who through the screening mechanism, they enter into your algorithm or flow pathway for diagnosis. So similar, what you do is that you screen, And screening is due to a test, and then you make your assessment, which is the diagnostic testing modality. So what are the tools that we would be required or would be needed for screening? Well, most of us will have some of these tools in your office, and the recommendation is that you really should have them all. So clearly you need to have a weight because, as I said, being obese is an important risk factor for diabetes. The ability to measure height, so that's a stadiometer. The ability to measure waist circumference, so you really need a tape measure. The ability to measure blood pressure, so you need a sphygmometer. Point of care devices, which could measure blood sugar levels and total cholesterol. And most of us will tend to use the FINDRISC tool as a questionnaire, tool, which has 8 questions. It doesn't require any testing, but it will identify individuals, asymptomatic individuals especially, who are at high risk of being diabetic, and therefore these individuals should be subjected to specific testing. Typically, a score of more than or equal to 15 increases your risk by at least 33% to as much as 50% with you having diabetes. The FINRISC tool, there are electronic versions available. So MD-Cal has the questionnaires already there set up. Medscape also has it. So for those of us who have access to the internet, we would be able to perform the screening using this tool. Similarly, you can actually print it. A copy of it is actually in the Ministry of Health screening guideline. So that's another way you could actually find it. As well as the World Health Organization cardiovascular risk prediction charts, which are also embedded within the MOH screening guideline manual. And these charts together and the information and the data that you get from performing these activities will allow you to identify individuals who should be tested further for diabetes. It is important that we look for opportunities to screen. Many of us do perform outreach care, outreach services, so at churches, some of us are members of service club. So these community-based activities provide a forum for which we can do screening for diabetes. Within our offices as well, when we do health maintenance visits, school medical employments, medical insurance, these also provide us with opportunity for screening, as well as when we do curative visits for other problems. And we really need to ensure that screening for cardiovascular disease, for non-communicable diseases, especially diabetes, are incorporated as routine activities within our office workflow. The issue, though, is that diabetes affects many systems within the body. And not only does it affect many systems, but there are many disciplines that will be required to offer services for the holistic care of individuals who are diabetic. And this diagram really just gives you just a rough idea as a range of individuals who are commonly, but it's not an exclusive list, who are commonly associated with the care. So therefore, the primary care levels, you have your diabetic educator, the pharmacist, your physical activity coach, podiatrist, your doctor, that sort of a thing. And then clearly when the patient has progressed and has gotten complications, you may have to go for more specialists such as endocrinologists if they become pregnant, obstetrician, and so on. So as you can see, this is not a overly exhaustive list, but it really just highlights the fact that despite the number of individuals and the number of specialties and the number of disciplines that have to interface with a client who has diabetes, the person with diabetes should actually be in the center of the model. So how do we approach an individual's definitively diagnosed or just anyone? The challenge we have is that diabetes, especially type 2 diabetes, it's really a disorder of lifestyle. And so how do we focus ourselves in terms of trying to ensure that we mitigate the risk associated or the risk that will allow us to develop diabetes? There are really five main pillars, I'm sorry, for this lifestyle management issue as it relates to diabetes. So there's nutrition, the issue of us becoming physically active, the limitation of alcohol use, not to smoke at all, and of course, where diabetes is concerned specifically, the whole issue of foot and eye care. So let's talk briefly about nutrition. Dr. Campbell will take you through perhaps some more details, but from a metabolic standpoint, what food does is really acts as a source of fuel. It provides specific nutrients which engage in chemical reactions. And the unit of energy, which you'll probably hear us talk about a lot, is kilocalories, really, which is the amount of energy that is consumed or released through the metabolism of food. So when you look at food, it can either go one of two ways. It can either go to build up stuff called anabolic processes, or the food can be broken down to provide energy, the so-called catabolic processes. And, you know, there's lots of things that's written, there's lots of things that's tweeted, there's lots of things that misconceptions that individuals have what it constitutes the right diet. But broadly speaking, conceptually, it's essentially the right diet is one that meets your client's body metabolism and their needs. And in giving dietary advice or making dietary suggestion, one has to be cognizant of their food preferences, their culture, what are the things that they're accustomed to eating, and of course, the person's lifestyle, the kind of work schedule, the different scenarios that they may be involved in. And the right diet is one that is accommodative of all of these domains. So it's not a specific set of standard set of items that you're going to give everyone, because each of our body's metabolism is different. There's an era in medicine now called precision medicines, where we're even trying to take it to the level of understanding the genomic expressions of individuals and to tailor your diet to maximize or counteract any adverse genomic expressions that you may have. And as we gain better understanding of that process through whole body genomic scanning, you know, it's the extent to which we can start tuning individuals' dietary prescriptions to more closely reflect their own metabolism even better. Just to say, clearly, one of the things or the basic concepts that we want to get across when it comes to diet is that you are only in balance when the amount that goes in through food and drink is equal to the amount that comes back out. So if you're gaining weight, it means that the amount that is going in is always more than the amount that's going out. The things that are responsible for metabolism is really your body functions and physical activities. So the only way you're going to be in a deficit is if the amount of calories that you're burning is actually more than what you consume. And so whilst it's a very easy concept conceptually, we recognize that in terms of implementing it in practice, it's very, very difficult. And that is one of the factors that contributes to the prevalence of obesity we have. Certainly within the context of diabetes, we recognize that a 3 to 7% weight loss in people who are obese will improve cardiovascular risk factors and our ability to control their blood sugars even better. And certainly if we're able to achieve as much as a 10% weight reduction, we can actually, and sustain that, we can actually see improvement in long-term cardiovascular outcomes and even mortality. So managing weight is an important concept in individuals with diabetes. And so broadly speaking, just to say that in the Caribbean, we recognize the 5 food groups and the 6 food groups, I'm sorry. And what we're suggesting is that the best suggestion you can give is to eat a variety of food from all the food groups, but regulate the amount of intakes that you have for certain kinds of food groups, like your fats and oils, and of course, the amount of salt and processed foods that you consume. But I said I'm not going to go into too much detail in this particular lecture about the approaches on the nutritional side. Just to say that nutrition has to be complemented by exercise, And exercise is really just a subcomponent of physical activity. So physical activity for us is defined as any bodily movement that is produced by the skeletal muscle that results in energy expenditure. There are several components to it. There's non-exercise activity thermogenesis. So those of us who are always fidgety and stuff, that's really what we call non-exercise activity. You're always on the move. You're always, moving about. And there's some data that suggests that individuals who tend to be very fidgety, as we call them, can't stay still, they are less likely to become obese. Individuals who tend to have low NEAT are more likely to be obese, and that makes sense. And of course, you have exercise, which is purpose-built physical activity that is planned, structured, repetitive for a target. The Jamaica Health and Lifestyle Survey, in addition to demonstrating the prevalence or the burden of diabetes, also gives us a clue as to why is it that that burden is so high. So when we look at the proportion of individuals who report that they're very, very active, that's roughly about 2% of the sample. The vast majority, 82% of the individuals, are in very low physical activity state. So exercise we recognize has certain physiological functions. There are two main types, the isotonic type and the isometric types. So the isometric type is really like weightlifting, and the isotonic type is really like more of a aerobics type. And most exercise will involve both types, and both types are actually very useful. And as we get older, one of the challenges we face is dwindling of the skeletal muscles, so-called sarcopenia. So in that context, isometric exercises are fairly important. So these are just roughly some of the independent benefits of exercise. It reduces the risk of dying, reduces the risk of you developing diabetes, reduces the risk of reducing blood pressure, and then of course it helps to control your body weight. The recommendation is that you should aim to engage in at least 30 minutes of more moderate intense physical exercise on most days of the week. Certainly, the total amount of duration for the week at the basic minimum is roughly about 150 minutes per week is a recommendation by most health authorities. So let's briefly just run through the alcohol component of the risky approach. So alcohol, the challenge we have is that it's socially accepted drugs in many countries. So in Western countries it is, in some Middle Eastern countries it is not. But certainly in where we sit in Jamaica, it is considered to be socially acceptable for you to go and have a drink here and there. The issue, though, is that if you consume alcohol, some individuals may actually progress to what we call alcohol use disorder. And one of the screening tools that we can actually utilize to assess that process is so-called a CAGE questionnaire, which really just asks 4 questions, and based on their response, if they have answer of yes to more than 2 or more of these responses, then this is highly suggestive of an alcohol use disorder. And of course, then we should employ or engage with our psychiatric colleagues to manage these individuals. We know that alcohol causes an increase in your blood sugar levels, and so individuals or patients who have diabetes and consume alcohol will have more challenges in terms of managing their blood sugar levels and managing their blood pressures. So overall, our recommendation is to avoid excessive use of alcohol and limit to about what we call 1 to 2 units per day. And on my slide here, I've given you some examples about 1 unit. So essentially it's about a small 77 mils of wine, about 220 mils of a beer is really what we would consider to be what you should consume roughly per day as some guidance. All right, so one of the other things that we need to recognize is that individuals who consume high levels of alcohol may also get hypertriglyceridemia, and with that they may get liver inflammation and pancreatitis. So that's something that we have to be cognizant of. Many of our patients will smoke cannabis, and some of them will also smoke cigarette. And those 2 bits will also make diabetes a little bit more challenging. Cigarette smoking is associated with some cancers, many cancers, in fact, especially that oral cancer, lung cancer. There's an increased risk of peripheral vascular disease, erectile dysfunction, and independently an increased risk of diabetes, right? The acute smoking of cigarette is associated with increase in the heart rate and, of course, a rise in your blood sugar levels. So individuals with diabetes and who smoke, they tend to have a higher prevalence of heart disease, kidney disease, and of course, eye damage. And so the recommendation as it relates to smoking and diabetes is that individuals should not smoke. General people should not smoke, full stop. And this is worse if it is that you have diabetes. This situation is not as straightforward with cannabis. We know that cannabis will affect your blood sugar levels and it can affect your weight. And within that context, because we know of the relationship or association between overweight and diabetes, it may predispose individuals to becoming, through that mechanism, becoming diabetic. Notwithstanding that, what we suggest until there's more robust data available, the recommendation is really to avoid cannabis use or limit its use where possible. So when we look at everything in total, as I said, diabetes represents a lifestyle disease, which requires us to be cognizant of the lifestyle management approaches. And one of the tasks that we would have as healthcare providers is to assist our patients to make more healthy choices. And if they do that, it usually will result in a more healthy person. So let's now look at the physician management of individuals with diabetes. So one of the things that we recognize is that with chronic diseases, you can't really manage the disease for the patient. You're there is really as a healthcare coach. And so within that context, it's a shared responsibility between yourself and your patient. And so one of the things that we'll have to get towards is really to assess and agree on what are going to be our goals of care. And broadly speaking, those goals of care could be divided into two main sub-goals. One is the prevention of complication, and the second one is to ensure that our patients enjoy the best quality of life that is possible. And in order to do that, we have to agree on what are the specific components of our management plan. We have to ensure that we review these plans on a regular basis. We also have to ensure that we agree on what are the milestones in terms of surveillance for complications, what are the things that we're going to be doing. But the long and short is that many health organizations are recognizing that the paternalistic approach to chronic disease care is unsuccessful and doesn't work. And so within that context, many organizations, so many of the chronic diseases are looking towards a chronic care model, which I just said. So this is just a further expression of that chronic care model. We're looking at a proactive, engaged participant in their own care. So when we speak about, since that hyperglycemia is one of the major manifestations of diabetes, a lot of the goals are related to the glycemic levels. And so typically most organizations have agreed on a 7% target, especially in those who are younger and who have a longer duration of life expectancy as the goal. Individuals who are much older and are very close to and have a lot of other challenges, where making 7 may be impractical, then we may have to settle with a target of about 8% for their hemoglobin A1C. So, as I said, diabetes is a generalized metabolic disorder. So not only would they have issues related to blood glucose, they will have issues related to protein metabolism, lipid metabolism. And on the lipid side, we also have specified goals that has been shown to reduce the risk of cardiovascular death. So LDL concentration, HDL concentration, the triglycerides. Blood pressure control is very important because diabetic nephropathy is a very common complication of individuals with long-standing diabetes. And one of the ways to minimize this is to really aim for much better or tighter blood pressure control values. And so the recommendations from most authorities is that we aim for our systolic blood pressure of less than 130 and a diastolic blood pressure of less than 80. We do now have quite a plethora of oral medications to treat diabetes. So, you know, metformin is the mainstay and the first choice and in most guidelines. We have the thiaglitazone, we have the sulfonylureas, we have the glutamides, we have the acarbose, which is their alpha glucosidase, and we have the DPP-4, which is the peptidase 4 inhibitors. We have our P1, which are the new kids on the block that everybody's getting very excited about, extremely expensive, not yet here, available in Jamaica. And then we have our sodium glucose co-transporter 2 or SLGT2 medicines, which has some data to say that they have additional cardiovascular efficacy. And so again, many of the societies and international guideline bodies are actually incorporating their use in the management of diabetes. So when it comes to implementation of pharmacotherapy, we recognize that the less is best if we can. So the goal, hopefully, is to treat them with the least amount of medicines, along with lifestyle management, that will achieve their shared goals. There is the issue of can we prevent diabetes? And there's some data to say that metformin therapy, especially for those who are very overweight, between 25 and 59 with very high BMIs, not yet diabetic, but might be in the pre-diabetic range, that giving them metformin may actually prevent them from progressing to type 2 diabetes. A colleague of mine was actually suggesting perhaps we may think about an intervention where we just like how we add sodium fluoride to our water to actually prevent caries. And that has shown to be an effective intervention. The question that was posed to me, have we ever considered adding metformin to water to see if we can, since so many people are obese, to see if we can actually prevent the thing of diabetes? So it's a thought. Something that, you know, is probably worth having a study designed around. Notwithstanding that, though, for those individuals who have established diabetes, we have a range of medications, oral medications available to us. Metformin is the first, but if person cannot tolerate it, then we have others that we can use, the DPP-4, the sulfonylurea, the SLG2, and the thiaglitazones. The challenge we have is that the specific choice is going to be dependent upon the goal, other characteristics of the patients, whether they're overweight or not, and any other clinical complications that may coexist. And so I'm here, not going to be here describing all the possible scenarios, but just to know that there are many inputs that we have to consider with our patients in order to select the one that is most appropriate. Certainly, if we're starting from a hemoglobin A1C of more than about 8.5%, because we're aiming to get them down to less than 7, dual therapy, you may start on that on the BAT. Clearly, individuals who have been on monotherapy 3 to 6 months, not have achieved their goal, they will have to be moved to dual therapy. And here, typically what you'll do is combine metformin with, or combine, depending on which one they have, you take one with a complementary mechanism of action to ensure that you get a synergistic effect from your dual therapy. And of course, sometimes we may even have to go triple therapy, and even sometimes we have to add insulin. So the issue with insulin is that in our approach to our patients, we should not use insulin as a threat. We know the cultural psyche in Jamaica is that individuals do not like to talk about injections. And so some of us as healthcare providers, because we are aware of that, we say, you know, if you don't take your tablets, then we're going to stick you on insulin, you know, as if using insulin in a threatening manner. But the fact of the matter is that notwithstanding our best efforts, many individuals, because there's progressive beta cell loss over time, many individuals, there's going to come a point in their journey when they're going to need insulin. And so the approach should be, what we are trying to do is to minimize beta cell loss so that you really don't have to necessarily get that. But despite our best approaches, some individuals, based on when we get you, you may have either lost too much beta cells already, or you've been with this disease, living with this disease 10, 20, 30 years, the possibility exists that we may have to be using this form of a combination therapy in that including of insulin. So the take-home message here is that certainly in our conversations and our discussion with our patients, try not to use insulin as a threat. We have different forms of insulin. So we have many options. So we have very long-acting ones, which maximal effect in 5 hours, flat effects, intermediate-acting insulin, of course, or very fast-acting insulin. So with that, now we have a lot of flexibility in terms of our approach to our managing of our patients. So I just wanted to mention this slide, which is a slide from the American Diabetic Association from the 2023 guidelines. And there's 2 elements of this slide that I really want us to focus on. One is that they have created a category over here that you see in the green, which focus on whether or not the diabetes or persons with diabetes have existing cardiovascular risk. And certainly if they have existing cardiovascular risk or renal risk, then the approach to them would involve some of the newer therapies in order to get some of the benefits that these newer therapies have been demonstrated in clinical trials. The other thing over here, which represents a traditional approach in terms of individuals who may not have cardiovascular risk at this point in particular time, but has diabetes and also may have weight issues, is the fact that metabolic surgery has really come a long way over the last 10, 20 years. So much so that it now has a place in what I call the standard of care management of individuals who have diabetes, because it recognizes, or it's an attempt to recognize the fact that being diabetic and being overweight and obese, not responding or refractory to standard medication is actually an increased risk of you dying from cardiovascular issues. And so we really need to address those issues. So those are the 2 main issues I just wanted to bring to your attention from this particular figure or diagram from the American Diabetic Association. So as we said, you really need to have access to your medicine. It's all good and well for that we say and we see these medicines do these particular things, but if you don't have access to them, then clearly they won't be able to do or have the effects that you want. My Dr. Campbell is going to speak a lot more about adherence and how we can encourage our patients to be more adherent. So that's a part of access. So having it, but it also needs to be inside the body in order for it to be of use. The medicines need to be affordable. So it makes no sense that, for example, we prescribe SGLT2 medicines, which are relatively expensive in our setting, and it's way above the affordability of our patients. So these are some of the things that we have to discuss with the patients, discuss with their families to see, okay, this set of approach is likely to be beneficial. How can we do that? The health system, in a sense, also has to be facilitator. And within our system, we have the NHF, and of course, we have the health insurance companies, which do provide some degree of subsidy and therefore increase accessibility for these medicines. We're prone to natural disasters. Climate change is coming. Well, it's here. Hurricanes are here. What happens when there's a hurricane? How do the patients ensure that they have continual access to their medications during and after these natural disasters? A couple of days ago, a couple of weeks ago now, we had a little wake-up call with a little earthquake. It could have been worse. So buildings could have gone. Individuals then may have had issues in terms of their medications. And one of the challenges we know with diabetes, especially if you have severe diabetes, is that you need continuous access to your medicine. So that's the thing that we always have to be factoring in. And so when we think about the chronic non-communicable disease, one of the things that we have to be thinking about are what are the social determinants of the disease itself, and in this particular case, its complications as well. So in any individual, there are lots of social factors that may impact their management. And as physicians or healthcare providers, as part of this multiple disciplinary team approach, we have to be cognizant of them. The social environment, crime, the physical environment. Some individuals live in neighborhoods that, you know, security is a big issue. They can't come out, they can't cross certain roads, they can't go to certain health centers, and that is going to actually increase their risk overall, and therefore allow them to develop more complications. So this is something that we have to bear in mind when we're thinking about how we are providing a holistic care to our patients. And so I'm going to be closing now by just focusing on the fact that during the course of my talk so far, I really just focused on individuals living with diabetes. But the issue is that the patient-centered approach really is an approach to focus on an individual in terms of their overall wellness. So wellness is different or distinct from being ill because it has other dimensions. So it has the mental, spiritual, emotional, social, and environmental component to it. And here, what we're trying to say is that wellness is actually, there's an element of proactivity where wellness is concerned, where we're seeking to encourage our patients to actually move towards that particular target in a more proactive manner through their lifestyle approaches, through interventions at the social environment. And of course, where important, especially for many people, is their own spirituality and how that allows them to center themselves within the world. So as we go along, as we manage our individual, as we adopt this patient-centric approach to our patient, the overall goal is to encourage our patients to be very proactive, very deterministic in terms of where it is that they want to be in life. So I'll stop and conclude where I started, in that the approach to the chronic care to the patients with a chronic illness is just not giving them pharmacotherapy. It's just not looking at the individual. It requires a village, it requires a community, it requires a health system that is facilitatory. And it requires an appreciation from the patient themselves that this journey is really a journey not to be free from disease, but really it's a journey for us to seek an existence that we can consider that we're well, that has a multidimensional approach to it. And together we can all work towards reaching that goal. So I'll stop here and thank you for listening this evening.
Thank you very much, Professor Marvin Reid. A very excellent presentation. Professor Marvin Reid spoke about Together We Can, a holistic approach to wellness with diabetes. And he explored the importance of lifestyle modifications, emotional support, and community engagement in diabetes management. I want to share with you, Sam? Hello? I want to know if you guys are seeing me. Yes, all right. I closed off my thing. All right, I want you to do something because it's for just a few minutes. We're talking about relationships. Nothing matters unless we have a good relationship with ourselves, with our God, with our family, with the people who are around us, and the people at work. If we don't have good relationships, we're going to have chaos, craziness, crime, and all kinds of strange, funny things happening. So I want you all now, just do this with me. Put your hand on your heart and just breathe slowly in and out. And feel the breath going into your heart area. I do it with my patients. Ask them to breathe into their heart. breathe into your heart and you feel it. We want to protect the heart. And as you breathe into your heart, think about somebody that you really love. And you put them right here. So you're breathing, you're feeling your heart beating under your hand. Breathe. And think about somebody that you love. And then if somebody else is close by, you can look at another person. Maybe you don't know that person, but you look at them with that warm regard and build rapport. The other thing I want you to do, this is an experiment I'm running with you. Breathe, do the heart breathing, breathing in and out. And just experience, you know, that warmth that the sun gives on your skin. Just feel that warmth and just place it in your heart. And it's that warm feeling that you want to have toward yourself to take care of it. Why are you going to do all of this if you don't love yourself? I want you to feel your heart and love your heart and love yourself. Because once you love yourself, you'll be able to love somebody else. Once you love yourself, you'd want more for yourself. You'd want yourself to be on the road to wellness, and then you can engage a conversation. If you don't feel, if you're not there yet, as a physician, we need to know when we are there. It's as Professor Marvin was saying, it's an exercise. However, when we practice regularly, we make progress. Isn't that true, Professor Marvin? Practice makes progress. So we want to actually get to love ourselves and get our patients to love themselves, get them to love other people, but they got to feel it. Because if you don't feel it, you're not going to do it. You're not going to stop smoking, you're not going to stop drinking if you don't love you. But you just got to feel that you love you. So put the warmth here, and you must know somebody that you love, and you feel it there, and then you have that, you can translate that when you look at somebody else and give them that nice warm regard. And then you have a conversation. You ask, you can ask. This is what we do as patients, as physicians. We assess, we advise, we assist, and arrange follow-up. We bring up something to us. This is their presenting complaint, and then you want to bring up the relevance of this to something that is going to really affect them, so that they can now get homework. Yes, your patients get homework. You should give your patients homework, because when they get homework, they actually build strength. All right. So, Prof, I really thank you for this. We got to really practice this holistic message, because practice makes progress. Love ourselves. Breathe. Let the patients practice breathing. Let them practice loving themselves. Sometimes they really go into a lot of depression. They need to quarantine from the social media or reduce their amount. They got to turn up for their practice. They got to turn up. They need to hang out in areas where they see people getting how they want to be. So if they smoke, they want to hang out with non-smokers. However you want to be, you want to hang out with that group. So if you want to be a criminal, you hang out with a criminal. If you don't want to be a criminal, you don't hang out with a criminal. You understand? Anyway, Prof, thank you so much. Emotional support is very important, but guess what? We've got to feel it in our heart, right? And sleep. Sleep is very, very important. Because once we do that, once we get good rest in our community engagement, even on the topic of diabetes, we'll be more holistic. Because then we'll be working together as a team to make a difference in each other's lives. And, you know, Prof spoke about the community. It's all about relationships, you know. So we have the monitors, and in the family unit, people are checking each other's sugars. We need to actually have the family coming in to show them how to cook. And I know the Dr. Jackie is going to deal with this. You've got to train the family, because you have a patient, but if the patient goes back to an area where there's no support, then what? It's just like the smoker. Before we had the public health law that stopped smoking in public spaces, there was so much trouble for the people to quit smoking. They were struggling. However, with support, they can. It makes a difference. So we need to set the right environment so that the plant can thrive. We've got to nurture this. So we need to nurture the family. Got to really nurture the family, but it starts here in the heart. You've got to love yourself, love the family, bring the family members in, and then work with the family. Right? Now, our next item is going to be a sponsor's presentation video. So Sam, let's have the TV works. Thank you very much. Sam, over to you. We're going to have the sponsors presentation video at this time.
Sit tight. Don't even take a bite. You don't want to miss the opportunity to win a prize in our Apotex Spotlight. Approximately 25% of Jamaican children experience some form of rhinitis or hay fever yearly in response to being exposed to an allergen. An allergy is an immune response to a foreign substance that's not typically harmful to your body. These foreign substances are called allergens. This may include certain foods, pollen, or dust. Your immune system's job is to keep you healthy by fighting harmful pathogens. The different classes of anti-allergy products available from us at Apotex are antihistamines, corticosteroids, mast cell stabilizers. Firstly, antihistamines are products commonly used to treat symptoms of allergy. These can be classified as being either first or second generation. The main difference between both generations of products is the fact that the second generation antihistamines are less likely to cause drowsiness and is much safer because they have less drug interactions. At Apotex, we offer two main options of second generation antihistamines, or apoloratidine and or apocytirizine. Apoloratidine is indicated for the relief of symptoms associated with seasonal allergic rhinitis, as well as for the relief of symptoms of chronic urticaria and other dermatological disorders. The recommended dosage is 1 apoloratidine tablet for those individuals 12 years and over, and for children 2 to 11 years of age, half a tablet can be given once daily. A special physiochemical property of our apoloratidine is the fact that it is scored, tasteless, and chewable, which makes it even more tolerable for the pediatric population. As for our apocytirizine, this is indicated for fast relief of nasal and non-nasal symptoms associated with seasonal and perennial allergic rhinitis and in chronic idiopathic urticaria. This molecule can be used to treat individuals 6 years and older by administering only 1 10 mg tablet once daily. As for our corticosteroid option, we have our apomometazone nasal spray. This is indicated for the treatment of allergic rhinitis, rhinosinusitis with bacterial infection, uncomplicated rhinosinusitis, and nasal polyps. In treating any of the above-mentioned conditions, 2 sprays in each nostril once daily provides relief for adults and children 12 years of age and older. However, in treating seasonal or perennial allergic rhinitis in children 3 to 11 years of age, only 1 spray in each nostril is required once daily. And finally, our mast cell stabilizer option, or apo-olopatadine. Agpj-Apotex is used to treat itching of the eye caused by a condition known as allergic conjunctivitis or pink eye. This medicine is also used to treat eye itching or redness caused by pollen, ragweed, grass, animal hair, or dander. Being a mast cell stabilizer and a selective H1 antagonist, Agpj-Apotex is non-steroidal and non-sedating, which inhibits the release of mast cell inflammatory mediators. The recommended treatment dose is 1 drop into each affected eye once per day.
Why should you prescribe the APO? Well, 1. You're assured of high quality. Our products are formulated to contain the same active ingredients and to produce the same beneficial effects as the originator they replicate. 2. You get affordability. Our products are at a price point that patients can afford. 3. Accessibility. Our products are well distributed in all pharmacies island-wide. 4. Our therapeutic range. We have a wide range of products in numerous strengths and forms. So please remember to add the APO prefix to ensure your patients receive a high-quality, affordable pharmaceutical option. Have an apotastic day.
Thank you very much, Apotex, for that presentation. Our next pilot is Dr. Jacqueline Campbell. Dr. Jacqueline Campbell is a family doctor and pharmacologist. She's a lecturer in pharmacology, pathophysiology, and complementary and alternative medicine at the University of Mona. Dr. Campbell also supervises the research of undergraduate and graduate pharmacology students. She has been a newspaper columnist, writing medically related articles in the Jamaica Observer, and a co-host of radio programs which promoted health education, specifically in complementary and alternative medicine. She is the author of the book, A Patient's Guide to the Treatment of Diabetes. She is a wonderful family doctor. And you know, a family doctor deals with relationships. A family doctor deals with family support and family support training for the family. And it is a pleasure for me to invite Dr. Jacqueline Campbell to fly this plane at this moment. Jackie, please come.
Hi, good evening, everyone. Good evening, Aldith. I'm going to share my screen. Sam, I may need your help. I thought I had it. Sam, are you with us?
I'm here, Doc.
Can you just upload my presentation for me, please? Wonderful. Great. So good evening, colleagues. Good evening, everyone. Dr. Buckland, thank you for the introduction. So my topic for tonight is access to care, dieting, and the adherence to medication, the successful trifecta to delay long-term complications, morbidity, and mortality in diabetes. You know, when I got this topic, I said trifecta. That topic was probably made up or by someone who has connections to the races. But anyway, let us start. Next slide for me, Sam. So the objective, serious to note, the objectives of this particular presentation would be to discuss the impact of access to care, dieting, or I'm going to call it appropriate food selection and consumption, and adherence to medication, on long-term complications, morbidity, and mortality in diabetics. Now, the theme for World Diabetes Day 2021 to 2023 is access to diabetes care. And we've been seeing this in the newspapers and we've been talking about it. But the key thing to remember here is that the focus of the campaign in 2023 is delaying or preventing type 2 diabetes and, of course, diabetes-related complications. And the slogan is, know your risk, know your response. Next for me. So we know that diabetes is a highly prevalent disease. And the thing about it is that it has important public health and public policy reasons. And what we know is that because it's a major public health problem, it's going to or can result in a reduction in the quality of life. Of course, it can have increased morbidity and, of course, mortality. And, of course, the progression is associated with numerous complications. Next. And I'm going to keep reminding you about this. If we decrease the complications, we can decrease morbidity. We can, of course, decrease mortality. And, you know, when we look at the patient, so I'm just going to add some context before I really start discussing the different areas. When you look at our patients, they have these challenges, and these challenges are on a day-by-day basis. They have this complex set of behavioral actions. Think about it. There's a meal plan. There's a physical activity. They need to take a medication. And of course, you know, some of our patients not going to be taking the medications as they should. They're going to add a little of this and a little bit of that to it, of course. And this sort of regime that they have to follow is going to be complicated by this need to integrate everything into everything else that they have to do in their lives. So you can see that our patients are going to have these particular challenges. Next for me, please. Now, to get into the meat of the matter here, this is taken from an article which was written last year by Professor Alverston Bailey, and it showed what we know already. The figures from the Ministry of Health and Wellness, which show that 1 in 8 adults is living with diabetes, while 1 in 4 Jamaicans is unaware that they even have the condition. And it is very important that us as healthcare professionals, we know how to detect and diagnose diabetes early so that we can help persons to live with this disease, live well with the disease, as Professor Marvin was speaking about. Next for me, please. Now, you have some critical components in diabetes management. Education is one. Dietary pattern adaptation, exercise, self-monitoring, smoking cessation. Stress management is very, very important. And it's something I feel that sometimes we don't really emphasize enough with our patients. We don't really have a conversation with them about the need to manage stress. And of course, the pharmacological interventions. Next for me, please. Now, when we look at diabetes education, why do we need to educate persons about diabetes? The fact is that, as it was stated before, many persons are unaware that they are diabetic, yes, and those persons who know that they are diabetic. They just kind of know they have a disease, but they don't know exactly what causes it, what they must do. So they're kind of like lost, okay? And they expect us as physicians to really guide them. So with diabetes education, it's going to help in terms of improvement, in terms of the knowledge and lifestyle changes. We need to have, of course, improved patient outcomes, as Professor Reid was speaking about, weight management, reduction in the glycosylated hemoglobin, lipid levels, and so on and so forth. Quality of life is important. And as I'll probably speak about later, depression is something that we have to be talking about. We have to be looking out where our patients are concerned. We also, with diabetes education, is going to touch on improved levels of physical activity. There's reduction with diabetes education, there's reduction, hopefully, in the need for medication, and people will also know how to use the point of care devices that are very necessary in terms of managing this disease. Next for me, please. So the lifestyle changes, we know these already: eating, weight control, regular physical exercise, smoking cessation, reduction in alcohol intake. Next for me, please. The lifestyle management here, when we look at this, we know that it's fundamental in diabetes care. So you have self-management education, you have self-management support, lifestyle modification. Next, we're gonna run through the next few slides fairly quickly, Sam. So the self-management, we'll know that this is a process that people have to go through, and it includes many of the things which we speak to our patients about: the meal planning, the planned physical activity, blood glucose monitoring, taking medication, managing episodes of illness, of, let us say, low and high blood sugar. So people have to know that if they start to feel a particular way, as our patients say in Jamaica, they have to ask themselves, could this be as a result of any disruption in my blood sugar levels? So if that is so, what must I do? So one of the things we have to say to them, you have to have a glucometer, and you have to, when you have the glucometer, you have to know how to use it. Many of our patients do not like to stick themselves. So they'll have the glucometer there, pardon me, and they're not really using it, or they don't know how to interpret that the readings that they obtain. And also, if these readings are out of range, what do they do? So these are some things that need to be done. Next, please. Again, we know it's a collaborative process. The diabetes self-management education is a collaborative process, and it's required for successful self-management of diabetes. Next. And of course, we know it is very crucial to motivate persons with diabetes, because one of the main reasons, for not adherence to effective self-management, and I'm gonna give you an example in a little while, is a lack of motivation. There is the absence of social support, as Dr. Buckland was speaking about, these relationships. People don't have this sort of relationship with themselves or other persons. So there's this absence of this support, and many people will say, I can't bother. I reach my 70, I might as well sit down and die. And of course, you have the disease-related implications. You have this fatigue, because many of our patients with diabetes, they not only are diabetic, they are hypertensive, they have the high cholesterol levels, they are obese, they have so many other things that they could be working on, could be experiencing. Next for me. And we can skip this slide. Next. Let me look at this case history, and I'm sure many of you have patients like this. And I'm going to give you these two case histories, and I'm going to go back to them at the end. So we have a 59-year-old female. She's employed, has a strong family history of diabetes, also a history of gestational diabetes. In January of this year, she was diagnosed as diabetic. And same month, January, I started her on glucophage, and I referred her to the diabetes educator, and she really took on that. And she started to do what the diabetes educator recommended for her. She also took the medication, and in May, you'll note that her glycosylated hemoglobin went down to 5.8%. Of interest, and I'll go back to this in a little while, she has health insurance and also an NHF card. Next slide for me, please. We have the next person, who is a 90-year-old pensioner, about a 17-year-old history of diabetes. So in other words, I met him 17 years ago. Diabetes and hypertension, variable medication adherence. Had the medication, but he said he's not taking them often. No dietary restriction. His wife unfortunately died. No one to cook his meals. And over the last, let us say, 3 years, marked loss of weight. In fact, for about 2 years, I didn't see him. And I was quite surprised when he came to the office. I mean, the loss of weight. December, a year ago, glyco-HB 13.8%. He refused to go on insulin. He says, well, you know, we all have to die one day, doc. It's just a matter of time for all of us. And in May, he reluctantly agreed to go on insulin. And it's because he found a neighbor who was able to give him the injections. In September, what I did is that Dr. Reid has a coupon, and I wrote up the coupon for him to facilitate him getting some bloods done. So I'm gonna see if he does the bloods and what happens, because we have to really work with him. Next for me now. So how can we delay the complications of diabetes? One, we're looking at improvement of access to care. We're looking at appropriate food consumption, and we're looking at adherence to medication. So as I said to my students, we're just starting the lecture now. So next for me. So access to care, next. So what is the definition of access to care? It is the timely use of personal health services to achieve the best possible health outcomes. And many persons face these barriers that prevent or maybe even limit these needed health services. And we know that what is going to happen is that there is going to be an increase in poor health outcomes and, of course, health disparities. Next for me, please. No, access is complex, and when I want you to really look at this slide, that if the services are available and there's adequate supply of services, the opportunity to obtain healthcare exists. And so this population may have access to the services. So now the extent to which this population gains access is going to depend on many things. Financial, it's going to depend on organizational, it's going to depend on social barriers, cultural barriers. And we can have access, you know, but it is going to be dependent on affordability. It is going to be dependent on physical accessibility and, of course, acceptability of the services. So it's not just merely the adequacy of the supply that is there. So that is why access is quite complex. Next for me. So I'm going to spend some time with this particular slide. Why is access to healthcare important? it's important because it impacts a person's overall physical, all aspects of the person are affected: physical, social, mental health status, very important, the quality of your life. The access is going to be affected. I'm going to start first with the cost of health insurance. So many persons, quite a few people have health insurance, but think about it. They have the health insurance, but many persons will tell you that within a month, depending on the medications that they are prescribed, within a short space of time, the medication money finish. So you can have the health insurance card, but the money that is there to help in terms of subsidizing the medication, that is going to be finished very quickly. Persons on fixed incomes, how are they going to manage? Frequently, they cannot manage at all. You say, yes, there's NHF, drug reps come and say, well, you know, there's NHF, and the NHF is going to subsidize, but I put it to you that, and we all know this, even with the NHF subsidy, I know my patients and many of your patients cannot afford some of these medications. The next one is going to be educational opportunities. You'll find that those persons who can really, they're reading, they are able to understand what you have to say, right? They would be more likely to follow what it is that is needed for them to obtain the best health care. Then there is trust in providers. Some people just don't trust doctors, or they will say, well, you know, I will go to the clinic, but I don't really like going to the clinic because I have to wait long when I go to the clinic. The doctors don't spend any time with me when I go to the clinic. When they tell me that, I say, but the clinic, you have so many people accessing the service, so the doctor may not be able to spend, let us say, 20 minutes or 30 minutes with you. And they say, it's true, you know, doctor, but. So that is the next thing. Well, we looked at the stable income and job already. Look at transportation. In my practice, which is in semi-rural Jamaica, which is Old Harbor, you'll have patients who are coming from the hills, and for them to access services. Talking about my service, you're talking about blood tests, you're talking about if they need to get any diagnostic procedure done, they may have to charter a taxi. Or if they have to go to the hospital to go to the clinic, or if they have to go to the nearby clinic, they may have to charter a taxi. And that, of course, is an additional cost, and they may not be able to afford that. So the barriers to accessing health services can lead to, as it says here, delays in receiving appropriate care, financial burden, and of course, the barriers can lead to preventable hospitalization. I can give you a story, and I'm full of stories. I can give you a story here whereby a lady came to me about, let us say she came about a month ago, accompanied, this is the first time she was coming, and she was accompanied by her granddaughter, who is my patient. And she says, to cut a long story short, that she's diabetic, and she stepped on something at her house, and lo and behold, that's my explanation, she had this ulcer on her foot bottom. So I said, but what did you do about it? She said, well, she never got to any doctor. She got to the pharmacy, yes, and she get an antibiotic. And it was actually an antibiotic suspension. This is a lady, all right? And a cream, and she using that. And not only that, what she did is that she took a knife and she cut out the liquor part of the ulcer. So you can imagine the state of the foot when I saw the foot. So I just gently said to her, please don't do this again, you hear? And I have to send you to the hospital. Well, good thing is that she never lost the foot. So that is a good thing about it. But if she had in her mind that she could readily access health care, maybe this would have been prevented. Next slide for me, please. Now, it was Professor Bailey who said, being educated is critical to diabetes prevention. And we had alluded to that before. And he said that people living with diabetes need to understand their condition, just what Prof Marvin said. They have to understand the condition. They have to know how to manage it, and they have to keep their knowledge updated. Next slide for me, please. So we're looking at, in terms of access, we're looking at access to diabetes education. And I'm quoting here what Professor Alverson Bailey said, over 500 million people are living with diabetes globally. And it is for this very reason we must unite in action and call on our policymakers to increase access to diabetes education to help improve the lives of people living with diabetes. Very important point here. Next slide for me, please. So this is a point for discussion. With all of the increased facilitation of access, I say this because more and more places, you have more and more clinics, you have health fairs, all of these places are available. You have the increased facilitation of access, you have intervention. The incidence of diabetes is not apparently decreasing. And why? So on one hand, we talk about the things that people need to do and so on and so forth. All right then, what they need to do. But if you look at what people are faced with, so we're going to talk about food in one slide or so, but you look at the food choices that people have, and many of our patients, and not even our patients, the population, what are they faced with? They are faced with foods that are nutrient poor but calorie dense. So if you have that, and that is what you can afford, this is as far as you are concerned, this is what you must eat. You don't know that, okay, then you're supposed to not eat so much of that food. You can see that people will be setting themselves up for diseases to occur. And that is just one point here, because we could probably spend a whole evening just talking about this. And next slide for me, please. So we're going now to appropriate food consumption. So many of our patients will be saying, "Ah, Lord, doctor, I'm diabetic now. So what am I going to eat?" Next. So the goals of healthy meal planning would be, you have to eat nutritious food. So your idea of nutrition, or the doctor's idea of nutritious food, may not be my idea or the patient's idea of what a nutritious food is. Have to achieve a desirable body weight, and persons may say, well, you know, everybody in my family, I come from a big breed, nothing I can do about it. Have to maintain normal levels of cholesterol and triglyceride. You know, of course, what that is meaning, that although that's a healthy goal, people are going to say, you know, doctor, I'm not going to take any other medicine that's going to make my cholesterol level go down, because you know them bad already. And of course, the goals of healthy meal planning would be to prevent complication. Next for me. So it was an Observer Monday exchange from last year. Dr. Julia Rowe Porter from the Ministry of Health and Wellness said that there is no diabetic diet, and how people with diabetes should eat is really how all of us are supposed to eat. So let us look at that in a little bit more detail. Next for me. So what we know is that consumption of this high calorie food, packaged processed foods. They have a high glycemic index, and eating those foods instead of those foods that take long to prepare are causing a challenge, and they are burning out your pancreas. But when we know this, and when I talk to the patients about this, they're going to say, well, you know, they may not have the time to prepare the foods how they are supposed to be prepared because they have to work. And we all know about the multitude of excuses and, of course, challenges that people are going to give us. Next for me, please. So we're all supposed to be eating healthily. So culturally, Dr. Rowe Porter says we need to shift in terms of appreciating what a healthy meal ought to look like. And, you know, I laugh at things like that because many times when I say to my patients who are diabetic, I say to them, so tell me, when you eat a rice and peas, how much you're going to eat? And they look at me and they say, but doc, you know, you don't know, say half of the plate I'm a rice and peas. And then when I tell them, let's look here, the portion size of rice for you is really half a cup. But when you say half a cup, you know, half of a measuring cup, people laugh at me. Next, I'm sure they laugh at many of you too. Next slide for me. So let us look first at what the American Diabetes Association is saying. So the American Diabetes Association, they use the term medication nutrition therapy to describe this coordination of dietary intake with diabetic therapy to achieve a favorable outcome. Next for me. So medical nutrition therapy can be used as primary, secondary, tertiary prevention measure into that modification of the diet in high-risk persons. So looking at your pre-diabetic persons, let us look at obese patients to prevent or delay the onset of type 2 diabetes. Secondary prevention now, looking at tight glycemic control by dietary modification, and of course, in doing that, we're reducing diabetic complications. And we know tertiary is where we're managing the diabetes-related complications. So we're looking at the cardiovascular disease, we're looking at the renal disease in those with type 2 diabetes. Next slide, please. So we know that this MNT can improve high blood pressure, dyslipidemia, and obesity, which we see in conjunction with many of the persons who have diabetes. And we already know that the diets with a low glycemic index is going to, improve the glycemic control. Next, please. And this is the evidence, that diabetes-specific formulae, which we see with medical nutrition therapy, can result in significant reduction in the HbA1c levels. And the Mediterranean diet is going to be associated with the largest reduction in HbA1c. So what is this Mediterranean diet? Next slide for me, please. So in this diet, looks healthy, man, jeepers, so very healthy. High amounts of olive oil, vegetables, legumes, the whole grains, the fruits and the nuts. You're gonna have a little bit of poultry and fish and so on. But you'll find that although that some of our patients can actually eat like this, many of our patients cannot really eat like this because they're going to tell you olive oil expensive. They're going to tell you that vegetable expensive. They're going to say, Lord, doctor, you know much for fish, and when we eat chicken, they will tell you. So let us look at the Jamaican version. Next for me. So this is actually This was actually created by Miss Andrea Hunt, a diabetes educator, one of the main diabetes educators, and she has trained so many other persons. And you will see that the plate here, you see that chicken. I have the actual, this in my office, and I show this my patients. You see that they have a leg and thigh, a small amount of rice and peas, and literally half of the plate is vegetable. So what I do with my patients is that I show them this and I back this up with a plate, which I have actually divided in 3. And I say, well, half of the plate should be your veg, and then no, quarter of the plate is going to be your carbohydrate, and then the other part of the plate is going to be your meat kind. Of course, we're going to have to tweak this depending on what sort of occupation this person has, okay? Because I may not be able to say give a construction worker a little bit of rice and peas. They might say, boy, doctor, I'm going to drop down. So, you know, you have to be able to tweak this for them. And the diabetes educators will say to you that they would want persons to have about 45 grams of carbohydrate at each meal. And you may ask yourself, what is 45 grams of carbohydrates? That is going to be, next slide for me, Sam. If you look on the middle part where you're of the screen here, highlighted by red, you see that one serving is about 15 grams of carbohydrate. So one serving of carbohydrate would be half a cup, measuring cup, of cooked rice, or say rice and peas. It could be one thin slice of bread, because when you say one slice of bread, my one slice of bread is not going to necessarily be your one slice of bread. You could have a really thick slice. A serving of carbohydrate could be, say, a slice of yam. And here we're talking about 2 ounces of yam. So when we talk about 45 grams of carbohydrate, we're talking about maybe a finger of green banana, 2 ounces of, let us say, yellow yam, and maybe, let us say, a small fruit. All right? Next for me, please. Next slide. So when we look at all of what I have said, some of the challenges will be the cost of food, because we all know that food prices are going up. The dollar not doing what the dollar used to do first time. Another challenge with our patients is that of having to cook different pots, as we say in Jamaica, because you may find in the family, one person may not necessarily want to eat what another person is eating. You have to have strategies where that is concerned. So you could have it like, if you're cooking a particular meal, you would have to say portion out what the family member with diabetes needs to eat or to be eating, and the other family members may eat how they want to eat. The same thing goes for, let us say, drinks that have sugar in them, or if the person is hypertensive, you want them to reduce the amount of salt that they're taking in. Another person will say, well, I have to put in salt in my food and I don't want to put in any salt afterward. So you have these little arguments that are going to take place, when in essence, what should happen, the ideal thing is that everybody should be eating healthily, because we see in families, sometimes you see these eating patterns which will give rise to disease. So one person may, let us say, be diabetic now, but the other persons, based on how they're eating, if they continue the same way, they will become diabetic. So you have this lack of support there. So those are some of just some of the challenges there. Some of the solutions, I mentioned the solution, one solution there. Another solution would be eating in season. I tell my patients to do this, eat in season. Some persons do things like they share their crops with their neighbors. So let us say, if I were to say, cook color, or not cook color, I were to say, grow callaloo, I would share some with my neighbor, that sort of thing. Backyard garden, and this is a very important point, backyard garden. You don't have to have a big space to grow any little thing at all. And this is something I talk about with my patients. So you could say grow your veg in tires, or my colleague, Dr. Wilson Clark, was reminding me that people could, if they don't have the let us say somebody's in an apartment, what they could do is that they could have these hanging containers whereby they actually plant their vegetables in. So they could plant the callaloo, they can plant the pak choy, they could tomato, any little thing like that. So you have to open the mind to the fact that we need to grow what we eat. And in growing what we eat, we can in some way reduce our expenditure, and we can eat healthily. Also, what is very important is learning about healthy cooking and eating. Believe it or not, this is something I talk about with my patients. I will share with them recipes that I will cook at home. Things like, for example, a vegetable casserole, how you cook a vegetable casserole. All right, then, things like that. So I will do that. Moving right along. Next slide for me. So the next one that we're going to look at is adherence to medication. Next slide. So adherence is really this process by which the patients take medications as prescribed. Take the medication as prescribed, but it's easier said than done. Next slide. Next slide. So when we look at the non-communicable diseases, or before that, Sam, all right, this one. The non-communicable diseases, they represent a significant portion of the global disease burden. That is something that Prof Marvin had spoken about in his presentation, and the NCDs are managed by lifelong pharmacotherapy. So, and we know already that effective medications would be the cornerstone of prevention and treatment of the disease. But according to the World Health Organization, the NCDs disproportionately affect developing countries, and among the patients who are affected, adherence to pharmacotherapy rates is less than 50%. And what is that going to do? That is going to result in costly public health challenge. Next for me, please. When we look at adherence now, we're looking now at research done in Jamaica. So looking at the Jamaica Health and Lifestyle survey, that was the one done in the last one, 2017. What that showed was that, as it says here, 22.2% of Jamaicans older than 15 years with chronic diseases reported that they were on medication for their condition. But of this amount of persons, only 40% reported that they always took their medication. Next for me. We know already when we look at the burden of medication non-adherence, it's widespread. And of course, it's going to have serious consequences, not just on the individual patients. It can have consequences on their families and also on consequences on the healthcare system. And of course, that is going to lead to, we know already, the poorer treatment outcomes, progression of disease, symptoms, and complications. That, of course, is going to lead to increase in health services utilization and hospital admission. Next, please. So with all of the challenges coupled with the limited resources that are available, that is going to lead to increase in morbidity and mortality. And we'll have to look at Jamaica. When we encounter all of these challenges, you know, you're going to have all of these challenges occurring at different levels of the healthcare system. And we as physicians, depending on where we work, we will have to be dealing with these particular situations as they arise. Next for me, please. So if we were to improve adherence rates, we could dramatically impact the patient outcome while at the same time reducing the overall healthcare spending. We know this already. Next slide. So what are some of the barriers to medication adherence? This is the one I want to stop at for a few minutes, Sam. So this is a table from research done by a number of researchers in Jamaica, including Professor Maxine Gosso-Williams and Dr. Carol James. So they looked at this is a table highlighting the overview of studies presenting measures of non-adherence among Jamaicans living with non-communicable diseases. I want you to focus on the part where I've highlighted it in red. So some of the reasons for non-adherence, reasons which I'm sure you would have encountered before: financial difficulty, insurance problems, which would mean that the insurance, you have some insurance, but it's just not enough to help. Medication non-availability at the local pharmacy. So medication you can't get at the pharmacy near to you. Okay, and some people just they can't, some people just cannot sometimes don't have the energy to go to pharmacy hopping to get other medication. And sometimes they have challenges collecting medication. The next one, which I see time and time again, is the high pill burden. And the people say, boy, doctor, I'm just tired of taking all of them medication. And some people, if the medication regimen is complex, pardon me, if it's complex, meaning that they have a shopping list of medications, and let us say they have to take 2 tablets once a day, 1 tablet 3 times a day, 1 tablet half hour before you eat, and another tablet in the evening, and so on. You can see what is going to happen to these particular persons. The next one that I will see in the office is fear of the side effects of the medication. We have to walk people through the side effects of the medication. Many of our patients will tell you that they prefer to use herbal medication because that is what they grew up seeing. They grew up seeing them granny use this, and they grew up seeing their mother use it, and they know somebody who go to the herbalist and them get treatment and them quite all right. Okay, some people feel that if them just have a little touch of sugar, and I'm sure many of you have had patients who have told you that them just have a little touch, it not really bad. They don't need to take any medication as such, and so on and so forth. Next slide for me, please. So this is actually a complex problem, many contributing causes, no one universal solution. Let us see what the next slide brings. So how can we improve adherence? We need to have some aggressive strategies and policies to achieve optimal medication adherence, not just in diabetics, but I would dare say in the treatment of other NCDs. And some of these policies that we what are needed, they may what they will do ultimately is end up with persons having a better quality of care and lower costs in terms of costs to themselves and also cost to, let us say, the government in terms of hospital care, hospital admissions, and so on. And of course, better health. Next slide. Now, again, how can we improve? Because we need to come up with some strategies here. I've already alluded to the fact that we have this, sometimes these complex regimens, the shopping list of medication. Very important for us to de-prescribe. This is something that I do, and I know many of my colleagues do. De-prescribing, you look at the person's medication and you ask yourself, is this appropriate for this particular person who is in front of me? What would happen if I take away this medication from this particular person? So this is de-prescribing, so they have less. Also, what we can do to improve adherence as much as is possible is that if you can prescribe medications, you have one tablet, let us say, with 2 active ingredients or even 3 active ingredients. And of course, we know that those may cost more, but we can say to the patient, yes, this may cost a little bit more, but at least you won't have 1, 2, 3 tablets to take. You won't be forgetting your tablets. So you will be feeling better. It's better for your health care. So you have to find a way to sort of sell that to the patient. The next thing would be medication review visits by the clinical pharmacist. So the clinical pharmacist, what they can do, again, they can help with de-prescribing, and of course, they can help in terms of the appropriate medication prescribing, especially for the elderly patients. They can also help to reduce polypharmacy. We have to reduce this polypharmacy, and of course, reduce the adverse drug events. We have some practical ways where what can be done is that I know some of the pharmacies overseas, they will do this. I'm not sure about pharmacies here. If that is happening, please let me know, whereby they will package the medications, let us say, for a day's medication in some blister packets. And that is convenient. So Miss Mary, no, she just have to take up this package, and this is our medication in the morning, and it will help. Also, what will help in terms of adherence would be, the tablet containers. If a family member, somebody, a neighbor, even a pharmacist, and I know the pharmacists have a lot of work on them, if they could just organize the medications into these containers, it will make a difference. And of course, it's going to improve the adherence. And of course, we can check on the persons to ensure that, they're actually taking the medication. Next slide for me. In terms of improvement of the adherence, you will find that if you decrease the cost sharing for those with pharmacy benefits. What I mean by that, if, let us say, those persons who have a health insurance card, if they have less of a co-pay, you may find that that is going to work, that can help them. Also, if the pharmacy benefit part is going to be increased, of course, that has to do with the actuaries and the insurance, and of course, it's going to have implications for premium, but I'm saying it anyhow. If you can have expansion of pharmacy benefits to greater numbers of patients, yes, that it can also help. If you have an increase in the subsidy for drugs used to treat, this under NHF, of course, used to treat diabetes and other NCBs. Yes, the next one now, drug companies, if they could implement programs to cover drug costs, even for a few months, that will help. You know what I do? Sometimes I beg the reps, literally beg the reps. I say to them, look here, Miss X, I want to put her on this particular drug in and it helping her diabetes. But guess what? She's a pensioner. She cannot afford this medication. You think you could just give me a month medication for her? And you know, many times I will get the month of medication and I call up Miss X and say, we get a month of medication. So now if you can afford the next month of medication, and the next time the reps come, I say, you have any more I can give? And you know, we do things like that. And I'm sure many of you do things like that. Next for me, please. So it's very important to have health conscious people. And when you have health conscious people, they will be motivated to leverage the health system to the betterment of their overall well-being. And that is going to, of course, all of that is impinging on education. Whoa, I've been chatting a lot. Next for me, please. This is my slide. Yes, I am a failed. I'm an artist. There's an artist in me. So how can we delay complications of diabetes? So we have education, yes, healthcare providers, you have the patient. Let me look at the patient. We're talking about the patient. We have to keep in mind the patient mindset. You know, when you're told that you are a diabetic, it does something to your mind, you know. It really does something to the mind of many persons, because I know of someone who, when she was told that she was diabetic and her figures were just quite low, you know, other people would say, boy, you're not really diabetic, you have a touch of the sugar, but that's not the point. She's diabetic. She started to lose weight, so persons started to, her family sent her for all the doctor sent her for all the investigations and so on. And one day she said, you know what? You know why I'm losing weight? Simple. I stopped eating. Yeah, she stopped eating. And the reason why she did this is that when she was growing up, there was a neighbor who was diabetic, and the neighbor had double amputation. So she remembered that. So just the thought of being diagnosed as diabetic sent her into this sort of anxiety and depression. The patient too, we have to keep in mind the quality of the patient's life. The patient, what is also important with to the patient is family, the relationships, as Dr. Buckland said. The family, the friend, support groups will also be important there. When you're looking at healthcare providers, oh gosh, there's such a long list. And of course, I would have left out a few people like the podiatrist, which you know is very important too. Physicians, pharmacists, nurses, diabetes educators. I don't think that we utilize the services of the diabetes educators enough. Nutritionists, the social worker, the psychologist, the laboratory support personnel, all of these persons are going to be important. When you look at education, it's very important to sit with the patients, not to frighten them, but to say to them, you know, Mrs. X, you're diagnosed with diabetes and understand how you feel and so on. But this is a potentially complicated disease and it can progress if we don't do something about it. And you know, you just list the possible complication, so they have an understanding. And this is the sort of thing where we have to reinforce, gently reinforce. And of course, food. I put food there, very important, because we have to ensure that people have to eat food. We enjoy food, but the food that we eat has to be nourishing to our bodies, and to ensure that the foods that we eat, they do not exacerbate the disease. Next for me, please. So we get back to our case history. So the 90-year-old pensioner, he has, of course, the thing with this history is that he's a pensioner. He has an NHF card, but himself just paid too much money and him just can't bother. He had variable medication adherence. I have medication, but I'm not taking them often. Wife died, no one to cook his meals. He can't cook. He refused to go on insulin. He has to die one day. And the good thing about it is that he got a coupon. I gave him one of the coupons to facilitate the blood investigation. So you'll find a gentleman like this will have many complications. So the next slide now is the 59-year-old lady. She's employed. She has health insurance as a result of her employer. She has her NHF card. And what happens is that when she was diagnosed as diabetic and referred to the diabetes educator, she decided to work with the diabetes educator. And so you'll see that her glycosylated hemoglobin in January 2023 was 6.9%, May 5.8%. And she knows her targets. She's very much aware of her targets, and she knows she has to go lower than this. Next slide for me. So what has worked for some of my patients? Well, pre-COVID, we used to have weekly diabetes education classes on the veranda. Anybody who wants to come in, and it was a sort of support group. So they would chat about what they do and so on and so forth. Helped tremendously. Referring to the diabetes educator, well, I wrote a book on diabetes. Copies are available for my patients to read, buy and read. And of course, that helps. Of course, you notice I said it worked for some people. Some people decide, oh, I can't bother with this at all, or they will do their own thing. And what I have to do is embrace what it is that they want to do for their own bodies. All right, next for me. So how can we delay the complications of diabetes? Well, improve access to care, inform persons about appropriate food consumption, adherence to medication, very important, very, very important there. Right, next for me. Thank you for your attention. Any questions?
Jackie, you can look in the question and answer
Right.
area. It says, what are your thoughts on soursop and bitter gourd as herbal means of glucose control?
You know, we have patients who will take that. But what I'm saying to those persons is that you always have to be monitoring your blood sugar levels and the glycosylated hemoglobin levels. So I have patients who embrace herbal therapies for their as part of their treatment, but at the same time, if you want to embrace that, you have to be monitored to ensure that you are at target. I hope I've answered that question.
Right. Okay. So the next one is anything new re gestational diabetes?
Not that anything new in terms of what diagnosis or treatment. The person didn't say, but there isn't anything new as such that I know of. I would need to find out what it is that the person really wants.
So, all right. So the person who wrote this, you can just add some more.
Yeah, you could add some more to that. Yes.
All right, thanks. Okay. Next person here. Can the Association of General Practitioners recommend any resources for private diabetes education? Where would one find or contact such professionals?
Okay. Well, I know the persons that I use, as I mentioned her name, Miss Andrea Hunt. She can be contacted, and I use Mrs. Michelle Isaacs. Those two persons, but there are a number of other diabetes educators around, number of them around, and they're very willing to help persons. But at the same time, what I've found happening with people is that they expect the other person to do the work for them. So we can say, recommend a diabetes educator. But you as the individual, you as the patient, you have to be doing the work. The work cannot just be done by the diabetes educator. So there are a number of them around. So I could just let the AGP know about these persons, and I'm sure they could inform AGP about the other persons around.
I think we could put it on our website.
Yes, that would be good.
All right. What exercise can be recommended for a diabetic who is non-obese? What exercise can be recommended for a diabetic who is not obese?
I would say, and I said to all of my patients, walk. Walk. Do that 30 minutes. Or, I'll let you know what I like to tell my patients. There are some videos on YouTube. One of them that I love to exercise to is Walk a Mile with Leslie. So I'll have my cell phone in the kitchen in the morning, and I am there walking along with Leslie because it's a very small space. I will demonstrate some of the steps in my office and show the patients that it's really a small little part of their floor space that is really needed. And you can walk 15 minutes, 1 mile in 15 minutes. Of course, afterwards you're sweating, but these are things that you can do.
That's right. You really don't need a lot of space. I do qigong, and so I do like there's one exercise called pounding the mortar, and I can't do that though. Anyway, but qigong is
yeah.
This other question. Thank you for your excellent presentation. Will the diabetes educator include physical activity?
Yes, they do. They literally are, they're like a coach, and they go through every aspect of the person, what the person does. They get to know this individual in front of them. So they will be there. A patient of mine told me the other day that she has to take pictures of her meal to send to the diabetes educator. That detail frequently. So that person will be guiding her as to say, well, this will be too much of this particular food or something like that. Very, 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 very.
Jackie, sometimes, well, I find that sometimes when I have patient who is struggling and the person has set their own homework, I will just use a WhatsApp and just check in on them, or they will, they just check in the week to see how, because it's just a matter of having that presence with the person that they're not alone.
Yes, that's
once they get the hang of it, there's this support, and then really feel excited to getting, they get in the hang of it. Really get in the hang of it, and then when they come back, you're doing all the measurements and whatever. Of course, they have to be doing the measurements regularly because they have to have the glucometer, and that glucometer needs to be part of a family discussion because other family members should be using the glucometer.
That's true. And you know what's important in terms of support too, we've had stories of like family members literally scorning people who are diabetic. I mean, it goes to be more than just this sort of support, you know, you should take your medication, you shouldn't eat so much cookies and so on. But sometimes it can be the sort of support that is needed is more than that, you know, and how people respond to you because you are perceived to be sick and on your way out. It really is a lot. So because of that, many persons become depressed. They become very depressed.
Once a family can get in on checking the sugar and, you know, encourage, you know, each other, you know, to get their sugar on target, just make sure that it is where it's supposed to be. Because once there's a diabetes in the family, they need to also watch.
Yes, because everybody should be eating healthily. So it's a family decision.
It is a family decision. Person here now, do you see an increasing number of young patients below age 18 with type 2 diabetes?
I have not been seeing that because I'm not seeing that many persons below 18. But I do know that what we have been seeing is, I know the pediatrician in the practice, we have been seeing a lot of the younger persons who are obese. So it's just a matter of time before I will say yes to this question.
All right. This question is for Professor Marvin Reid. Is the chronic care model taught in medical school at this time? This is Dr. David Jemmott. He's saying, is the chronic care model taught in medical school at this time? We found as part of the MOHW IDB HSSP that a lot of providers were not aware of it and its benefits.
All right, so the short answer to that is I teach it when I do the chronic disease modules for the family medicine students, as well as for students who rotate coming to health practice with me. I also expose them to the model. It's something that you've brought up, so it's something that I will have to sit with my colleagues in community health and psychiatry to ensure that it is a systematic delivery throughout their curriculum.
Yeah, because it's so important, you know, this is a way forward. Thank you so much. And this other question, 29-year-old female patient recently diagnosed with type 2 diabetes, placed on metformin, however non-compliant. Patient complains of diarrhea and dizziness when taking metformin. What would you recommend for this patient?
Well, if I may have a go at it first, I would want to find out about what else is being done for her apart from being placed on pharmacotherapy. What about lifestyle intervention? If she's non-compliant, because she's non-compliant with the metformin because she gets sick when she takes the metformin. So think about lifestyle changes. Also, there are formulations of metformin, you know, that if the metformin extended release that you could take in the evenings, I find that taking that many diabetics don't get so sick. So we'd have to find out about the formulation of metformin that she's taking. If it is that she's doing all the lifestyle changes and she's not at target, and I mean, even if she changes to the extended release metformin and she's still feeling sick, we would have to start her on something else apart from metformin for her to reach her targets.
Right.
Yeah, that's what I would say.
This other one, what are your thoughts on utilizing physiotherapists in primary care to improve and facilitate physical activity in diabetic patients? That's a very good.
Very good.
Excellent.
Excellent question. Used to do it in the office when we had a physiotherapist. She would be part of the classes and she would really take the persons through different activities. So you'd have the structured program and instructing them about what they should do. Very good. Very, very good suggestion.
We really need to use a physiotherapist more. You don't have to wait for something to happen to the patient because it's a lifestyle. The patient needs a coach, and the physiotherapist will help the patient to learn the proper way of doing certain exercises. The patient may actually be doing something and injures themselves, but if they really have a proper guide, then they will be practicing. I say perfect practice makes progress, because you can practice the wrong thing and end up.
That's true.
And
get
really
the wrong results. Yes.
So we really want to know that we're practicing the right way. What is this other one here? Patients with an HbA1c reading that falls under the pre-diabetic bracket, what is their management to prevent diabetes?
Patient with HbA1c reading that falls under the pre-diabetic, what is it prevented? Lifestyle.
Include, sorry, I haven't finished, sorry. That's reading something. Include how often they should test to keep track of their blood sugar levels, please. So the person is under the pre-diabetic bracket, but apparently they must be very close to it. How often should they test to keep track of their blood sugar levels?
Well, I would say lifestyle intervention for sure. I would want to know more about this particular individual. Does this person have, for example, another NCD? Does this person, for example, is the person obese? Anything like that? All right. So I would want to know, and then that is gonna guide me as to how often they should track their blood sugar levels. I mean, formally, when it's a blood sugar levels, does she mean HbA1c or fasting blood sugar levels to or postprandial? I'm not sure.
She just said HbA1c. This one here. How can I gain access to the diabetic educator?
If you guys put it up on the website, that is one way. That is one way to get access to them.
We will follow through with putting the diabetes educators across the island on our website. Jackie.
Yes, Aldous.
The moringa leaf is a very useful vegetable. Have you ever cooked with it?
No, I haven't, but I know persons who have cooked. They kind of steam it down like callaloo.
Right.
They steam it down like callaloo. All of these things, you know, they are like adjuncts, and they're a way of expanding that which we eat.
Do you know that the moringa leaf tastes like lettuce?
Is it?
You can literally put it in it tastes like lettuce.
Okay.
It really it doesn't have a funny taste. What about this fruit that is so abundant, the Java plum? That red.
I don't know about that.
You don't know it.
No.
I was just thinking because no, I'm just talking about fruits and vegetables, part of lifestyle. Because I think if they got just a few fruits, they don't need a lot, maybe 2 or 3, and they make a jug of juice for the family. Because it's full of flavonoids.
Yes, but you see, what happens in our setting is that when people make the juice and they have your red juice in the fridge, what they're putting in it? Too much sugar.
We need to, it's education again.
Again, it comes down to education. How can I make a fruit juice which is going to be filled with the nutrients without packing it with a lot of sugar? And you'll find that if you extract the juices, okay, let's say you have a juice extractor, you're going to be getting a lot of the nutrients there. You don't need much of the juice at all.
Yeah.
But it's when you start to add a whole heap of sugar and a whole heap of this and a whole heap of that, that is when it's going to throw things out.
Yeah, so I brought it up because I know fruits are really expensive.
Yes.
And people who have, literally, I've seen Java plum, even in inner city communities, and it's just dropping on the ground, being wasted because if you taste it, it's very stainy. But if they allow the fruit to ripen properly, it's fine. And the other way is if they just put it into a drink, add no sugar. Literally, you can put ginger if you want, you can add lime juice if you want, but it tastes lovely on its own.
Yes.
And you do not make it strong because it's quite a rich fruit. So they can make a big jug just with a few berries. And I think people should just collect these fruits and they can put them in empty plastic bottles and freeze them. And when it's out of season, they just take a few and make a drink. Your family will get fruit.
So this is what we mean by a change in our culture.
Right.
In terms of how, when you have a juice, what is it that you are going to do with this particular juice? You're going to add sugar to it, but it is possible that you don't know how to fix the juice without sugar, or because of your taste, you're accustomed to a sweet taste.
Yes.
And then when you have something that doesn't have in that amount of sugar, you say, God, this tastes terrible, it tastes nasty, as my patients say.
It's retraining the taste. Yeah. But as I said, once we love our hearts, we love our hearts, we want the heart to keep, we've got to love ourselves, love our hearts, and it will keep beating.
It will keep beating, it will keep beating.
Thank you so much, Jackie. Wonderful presentation.
Thank you.
And for the audience, wonderful questions. You have really been an awesome group. And to our sponsors, Apotex, really, you've really helped us a lot, and to bring the message right across, not just Jamaica, but the Caribbean and internationally. All right, so I know we have a post-test, so I would invite Sam to put up the post-test.
Thanks so much, Doc. Post-test is up. Ladies and gentlemen, thank you so much for joining and the wonderful participation. Post-test is up in the chat.
Yeah, as you're doing the post-test, shall I allow them to just do the post-test and then we have the vote of thanks?
No, we'll go right into the vote of thanks now.
Okay.
The post-test will stay up, so even after the webinar, they'll have access.
Wonderful. So Mrs. Abigail Hay, who's a medical rep for Apotex, I invite you to come and give the vote of thanks, please. I'm going to do my post-test now as well. Thank you. Everybody, thank you so much. Professor Reid, Dr. Jackie Campbell, Apotex team, Miss Judith McBean and Miss Abigail Hay, Sam, our engineer, and Lynn, our wonderful administrator. And thank you all the participants throughout Jamaica and the Caribbean and internationally. Thank you so much for making World Diabetes Webinar Day part of your night. All right. I'm sure you're going to get 100% for your post-test. So just do it. Have a good night. Bye-bye.
Good evening, everyone. As Dr. Buckland would have mentioned, my name is Abigail Hay. I am one of the medical representatives with Apotex, the co-sponsor of this evening. And on behalf of AGPJ and Apotex, I would like to thank the following persons for their participation, their assistance in making tonight a success. So firstly, I would like to thank Dr. Gordon, the president of the AGPJ, for, of course, allowing us to partner with AGPJ for this webinar. I'd also like to thank Dr. Buckland, our moderator this evening, for taking us through seamlessly and graciously. We thank you so much for that. To our presenters, Dr. Campbell and Professor Reid, thank you so much for all of the information that you have imparted to us today. Doctors and even myself, not practicing, but the information has been invaluable in terms of educating persons on diabetes, as well as how we can practically help our patients. So we thank you so much for helping us with the holistic approaches and those practical approaches that Dr. Campbell would have also mentioned. Thank you so very much. To Lynn and the AGPJ Secretariat, we want to thank you so much for all of your hard work. We want to thank her assistant as well, Sylviane, all of you for all of the work you put in behind the scenes to make tonight a success. We thank you so very much. To Mr. Heron, who is from Oldgate, thank you so much for all of your technical expertise that you continue to share with us, making sure everything runs smoothly. We really could not have done this without you. To all of our attendees, thank you, thank you, thank you. Without you, this would not have been possible. It would not have been a success. So we thank you for logging on. There's so many other places that you could have been, so many other things you could have been doing, but you chose to spend your night with us for this webinar. So we thank you so very much for your participation. So thank you from Apotex and AGPJ, and please have a wonderful night. Thank you.
Since 1974, Apotex has been committed to helping enrich lives globally by providing affordable bioequivalent pharmaceutical products that meet the most rigorous quality standards worldwide. Since 2005, Apotex has dedicated billions of dollars towards the development of bioequivalent generics and, more recently, biosimilars, over-the-counter products, and food supplements. Our manufacturing capabilities are recognized by regulatory agencies around the globe as meeting and surpassing the requirements of global healthcare agencies. Delivering quality products to our customers is at the heart of our business. Our commitment to excellence in quality, R&D, and customer service through an established network of international branch offices and distributors has enabled us to grow from our humble beginnings in Canada to a presence in more than 115 countries. With a manufacturing capacity of approximately 30 billion solid doses per year, we are able to reach new markets and grow in existing markets while sustaining our commitment to excellence. Through our strength in research and development and our sustained dynamic intellectual property initiatives, we challenge patents and strive to bring many key products to market sooner. The breadth of our product portfolio, together with our sales and marketing strength, make us #1 in Canada, as well as having a leading market presence in Australia and US markets. We are also vertically integrated into many raw materials, helping us to drive synergies across many key products. We are proud to say that we continually donate medicines to disaster zones around the globe. As leaders in our industry and as individuals, we make an impact. We learn and adapt every day. We will continue to be recognized as a global leader by continuing to build valuable long-term relationships where customers get the products they need when they need them. Apotex, helping enrich lives globally.